How many hospitals did you have?
Oh, we had 24.
So I'm hearing you say that you had 35,000 employees that your name was probably on their paycheck and you still struggled.
I mean, it is hard to align people. I mean, first of all, you have to be in...
Scott Reiner was the visionary CEO leader of the faith-based nonprofit Adventist Health from 2014 to 2021.
But you have to have a destination that's different and greater than what you are. I cannot stand settling for average. And as a leader, you should spend at least 30% of your time, understanding the community that you're around and what the health needs are of the community. Everybody agreed to that in principle. And the people who embraced it the most were the employees. When you get into leadership and management, it was tough. And the closer they get to you, the harder they can resist.
Why is that? I'm Judson Howe. I lead hospitals. I've seen a lot of what's broken in healthcare, but we're going to find out ways to make this better. This is Healthcare Reframed. This one's Scott Reiner. He was the president of Adventist Health. It's a 24 hospital system in California. 37,000 associates, $6 billion in net revenue every single year, over 80 communities served. He was a nurse that became a top executive. He bought the Blue Zones. He chaired the California Hospital Association. But for me, he was the president of the system that I was a leader in. And I didn't understand at the time how much he impacted the way that I thought about healthcare. I couldn't think of a better place to start this journey. I have a few burning questions for him. I hope you enjoyed this conversation. Scott, you led a multi-billion-dollar system. I think you had about 35,000 employees. Why'd you walk away?
When I started as a CEO, I remember talking to our board very early on. And I said, I really only want to do this for 8 years. I kind of said, our forefathers had this idea. It sounded good to me, 2 terms. I don't think the board believed me. But my wife and I are quite intentional. So about year 6 or so, we really started thinking about what's next. So I never really wanted to do that job more than 8 years. I'd been in the organization for 20-some years.
Right.
So it was very intentionally designed to reinvent and do something different.
What was that first 3 to 4 months like for you personally, and maybe your wife as well? What did that feel like post-executive leadership?
Well, I read all kinds of books. I read books on how to unwind your career and how to reinvent yourself and, have an executive coach. We worked through all this. In the first 3 or 4 months, I was like a fish out of water.
Yeah.
My schedules were controlled by my work. My work community had to be tied. My community was tied to the health environment, other than family and friends.
Yeah.
It was the end of COVID, so I'm bouncing around the house with my wife, and she's not used to me being here. And I'm like a hammer looking for a nail to do something. I need to be in charge of something.
Yeah.
So it was actually more difficult than I thought, even though you can intellectualize doing something different. That shift is actually quite difficult. And I think it was actually more difficult than I thought it would be. Even though I wanted to do it, it was my choice. And I had an idea where we were going next with it, but it was a difficult transition. It took a few months or a year.
Was it harder for you or for your spouse?
It was hard for both of us because it completely disrupted our world.
Yeah.
She had the way she did things, the way she wanted to do things. I'm used to being, in a work setting. It was difficult for both of us, to be honest with you. We had more time together, but there was also, at my level, probably some frustration, a little bit like you're used to being in charge of something, and now what?
When you were an executive in healthcare, were there times that you questioned?
No. I always felt I started with mission, right? So I always felt healthcare was a missional calling for me. And, I came out of a background of faith and my father's a minister and my mom was a nurse and and I chose nursing actually as a background. I'm a nurse by training. And so I always thought healthcare is amazing. I thought it was the greatest opportunity to affect people's lives. The challenge came into it. The older I got and more experience, I thought we could do a lot more than we were doing in healthcare. And that became a touch frustrating to me. But healthcare is an amazing platform to doing so many things, intellectually, humanitarian, faith calling. Yeah, it's incredible. So I never questioned being in healthcare. No.
You mentioned just a second ago that there were things you wish you could have done, and maybe there was some latent frustration there. Give me an example of one of those things you wish you could have got done.
Depending on where you are, you could be in an urban setting, and where I worked in Southern California, you would have 5 hospitals, and if you're at a high enough point, you could see all of them at the same time. You can look over to the city and see your competitors or your allies, or
right.
you know what I mean. Or if you go into a small community, that's very different. Small community, you are the sole community provider. You're the largest employer. You often will have some of the brightest people, not disparagingly other people, but you a lot of well-educated,
Sure.
trained people that have resources. And I always thought we sub-optimized that in some of the communities that we're in. We weren't doing enough, I think, in the communities. So that's what created a lot of stimulation around really investing in community health, investing in side business, other health-related businesses that could do something for that community, in addition to providing outstanding medical care.
What would you say to someone who says that's not the role of a health system?
Well, I think you'd have to ask yourself, do you have the right definition of health? Because if you look at health, I think, and you can look at many different definitions. I think if you want to say you're a medical system, that's awesome. You're providing medical care. It's transactional, generally speaking. In this country, it's transactional care. You have an issue. We have something to diagnose, something to treat, something to educate. When you go home, we don't stay attached to you very much. Or are we providing an environment in the community that people actually know how to seek care, when to seek care? We have a greater role to play in health. Health has many aspects to it, and other than the actual delivery of care. So when someone says they're a health system, I'm going to make sure I see some other things involved other than surgery centers and diagnostic centers and hospital beds, which is amazing. We have to have that. But that's great medical care. Health means the community is actually involved. They actually have an idea about what health means for them individually and at a community level, and there's an ongoing dialogue and conversation about the role of that provider or the role of that health system in your community, especially as a nonprofit, even more so. I mean, you essentially are foregoing taxation in order to do something for the benefit of that community that they're not getting taxes for. So there's a little higher calling, I think, than providing only medical care, which I think is amazing, not discounting that.
Yeah.
But we have a higher calling, I think. I've always felt that.
So you seem to have, I'll use the term moral compass, maybe some values that align with what you do. Is there a moment early in your career, or maybe some moments that you could highlight that were impactful to create those attributes for yourself?
My background a little bit, working in faith healthcare or faith-based healthcare, I love whole person, physical, mental, spiritual, and I thought physical, mental, spiritual, then community. So I think there was 4 aspects of that was trying to ingrain into the work that we were doing. There were people that influenced me. There was individuals, either physicians that I've seen that were very open to and engaging in the community in a different way. There were entrepreneurs that thought about how to take a medical product and to create something that's a different kind of a business that supports the health ecosystem. So there's probably many pieces. I don't know that there was one specific person or specific time that was an aha moment for me. I think it was built over time. It's over watching things work or not work, or watching the disconnect between someone who comes into the organization and leaves. We don't know them anymore. I mean, they become something, they move back into the community, not to be seen until the next medical intervention. That doesn't feel like health to me. That feels like medical system or medical care.
Many experts note that only about 20% of health outcomes come from clinical care, while roughly 80% stem from social, behavioral, environmental factors. How does that relate with your philosophy around healthcare?
I believe over time, watching and participating in healthcare, it's very, very true. So if you take an environmental situation, if it's a very poor community, there's significant aspects to someone who lives in poverty, right? It's a mindset. It's lack of nutritious foods at times. It's education around lifestyle. It's some kind of chronic diseases, conditions that are brought upon because of the effects of poverty. So that could be one aspect of it. So our environment plays a role in that, absolutely.
Do you have any experiences where medical interventions were not enough for what you were trying to accomplish?
If it would be that case, it would be around chronic disease, possibly, thinking about that for a moment. If there's not a community of, if the organization of the health system or in a community are in alignment, you think of blue zones as an example, they work very hard to try to create an environment in the community that would create nudges or conditions that would allow the person the greatest chance of managing their health. And so that would be a good example of influencing the environment. So when someone is discharged or has a patient experience and goes back, there's certain signals and certain environment around them that demonstrates or nudges them in the right direction for making the right health decisions. So I think there could be a lot more done than has been done in the traditional hospital setting. I think there's a higher calling.
Imagine yourself in front of U.S. policymakers. What's a statistic, a single statistic, or maybe a lesson that you've learned in your career, maybe even your more recent career, that you would want them to remember?
I think it has to be around health behavior. I know it's very, very hard. We've tried this forever in this country, but we still have to keep working on people taking more responsibility for their own health. And there's a term, at least in public health, that we use, and it's called health-seeking behavior, and that is starting at a very early age to train people, or train, educate, encourage to know the various changes, either in their as they grow, or the types of when they should seek care, when they should be counting on a health system, or when they should be working or collaborating with other people in their community around the environment that is more conducive for them solving their own healthcare issues. And I'm not talking about chronic conditions or cancers or different types of things, but for basic primary preventative services. I think we could talk about our systems, about encouraging, knowing how to seek behavior or seek health in a different way than we are today. I think today we have a condition, we know we can go to the hospital, we know we can get something solved. We don't take as much responsibility, I think, as we could. So policymakers could try to encourage that. It could, through educational systems, through requirements, I hate to say that, even on health systems to do more for their public benefit, to do something more than only the delivery of the service.
You say we've known this for a long time. Why have past interventions not moved the needle?
I'm not a health expert in that respect. It's hard for people to change behaviors when all around them around them is not giving them the signals to do so. I mean, and I think there's expressions to the fact, if you want to be healthy, have healthy friends. I think it's very complicated. I think in this country it's exceptionally complicated because it's a very individualistic community, and we always want to do what is satisfying to us.
Right.
And and everything's available to us. It's a wide abundance. Everything you want in this country is available to you. You want to eat something, you want to do something. I just want to be on my computer. I don't want to exercise. I don't need to. I can just order it on my phone. So this technology is not enabling natural movement either. So I think there's some things in this country that make it complicated. And what I say is not easy, but we have to continue to work towards that. And policymakers, I don't know. To be honest with you, I don't know if it's not going to be something that's going to be driven by policy. It has to be a movement. There has to be energy from another angle that would be motivating to people. A policymaker is not going to motivate anybody.
You talk about Wellbeing Multiplier.
Right.
Which, educate me, but the way I understand that is multiplying a couple different facets, maybe health and well-being, or health and income together. And they seem to fuel each other, if I understand that correctly. Where did this philosophy begin for you?
Well, it didn't start here in the U.S. It started with our work in Zambia, actually. And this could be very much related to an impoverished community, although there are an incredible amount of impoverished communities around America as well. I think the two things that people that hunger most for is health and income. If you don't have health, you can't generate income. right? And if you don't have an income, it goes back and forth. But the idea is if we can, if people can put food on the table, they can have an income to support their family. And then when there are health conditions that need care, this especially in Zambia, when they show up to actually get the care, there's actually the equipment, and the equipment there is actually or the facilities are there to actually care for the individual.
Right.
Or the providers are there to actually do the work that they're trained to do. So health plus income has a multiplier effect. So that if you think of well-being, there's many aspects of well-being. Health and income or prosperity are just two pieces of well-being. There's education, there's advocacy, there's voice. There's so many pieces of well-being, but when you're strengthened with health and income, you actually have the ability to materially enhance the other aspects of well-being in your life.
Yeah.
The conditions become easier to attain.
I'm thinking back, I've heard many years and that, health investments can arrest poverty in lower income countries and probably most countries. I think the World Bank has actually used those terminologies. Mm-hmm. Is what you're saying with this well-being multiplier a modification of that research and some of their thoughts around that? Or where does that come from?
Give me your,
Yeah. And so, the World Bank talks about investing in healthcare, arresting cycles of poverty.
Right.
Are you disagreeing with those studies?
No, I think, but health is only one portion of it. If you obviously have to have a reasonable health condition for you to work, but honestly, and as much as I hate, the money does make the world go round. If you do not have income, you can't buy food. If you can't buy food, then you can't have nutrition. You can't have nutrition.
Yeah.
In impoverished countries, I don't care how much health care they have. If you have, if you're stunted, if your growth is stunted because of lack of nutrition and protein and other types of, you're already behind.
Yeah.
So you're going to have a health intervention, but you're already moving towards a chronic problem. So I do think, I'm not discounting that, but people also have to have income. We have to be able to help create jobs, or there has to be a way that they can sustainably care for themselves. And healthcare in these countries is not free either. I mean, while it's a government opportunity, it's not free when you have to go 20, 30 miles by foot or by a taxi in order to go get basic routine health care. It costs you money. Or if you have to leave your family farm and you're not producing income because someone's chronically sick because the facilities around you do not have the equipment or the supplies or the providers to care for you, or they don't have the diagnostic capabilities. So healthcare is you may not be paying cash at the door, but it's a huge chronic. When it becomes a chronic condition, it's very destabilizing to their income generation.
Do you find the idea that we should be doing both to be unpopular, or do you find support as you're talking about
I
this?
think you do both. You have to do both. They go hand in hand.
It reminds me actually of a much older study by a guy named Jay Forrester. And he talks about a different topic, but it reminds me of that, Scott, where, for many years, the United States would invest heavily in low-income housing.
Right.
And he was looking at sustainability of systems.
Right.
And he suggested that you shouldn't just be investing only in low-income housing. You need to simultaneously be investing in meaningful jobs and employment.
Absolutely.
And if you don't do that, you're actually creating capacity for lower income attributes in your community without any sort of exit strategy for that low income.
You're self-perpetuating the poverty cycle because you have a roof over your head, and if you don't have an income, you just have a roof over your head with nothing to do during the day. I don't think you can do one without the other. They exponentially support each other. So in our work that we do in Africa, we do side by sides. So we make sure, on one hand, we teach people how to generate or teach people how to financially be more self-sustaining. We teach them a job skill. You can give them microloans, certain things they get started. We help them take their products to market to get the best value. When they do that, then they have a little extra money to spend on some preventative healthcare things that are not naturally available.
Yeah.
It goes back and forth. They go hand in hand. I mean, if you've ever been really poor, which I have not been, or really ill health, which I can't say that I have been, but either one of those are destabilizing completely. So they do go hand in hand. I can understand the study. If you just have housing without jobs, you just have housing.
A moment ago, you said we probably need to define health maybe differently.
Right.
Do we also need to define income as well? And how would you define income?
For us, income would be getting to a level that's not poverty. And there's all kinds of indicators for that. I can speak to the country we're working in. So the average person we're working with is making around $50 a month. That's not enough to sustain food. Mm-hmm. It's not enough to sustain anything else in order for emergencies, for any kind of extra supplies for an education for their children. So that's a problem. So I think there are all kinds of levels of poverty lines of what is an income, what is the right income. Our target is to triple the income and to create essentially generational. For a poor community, it's generational wealth if you can triple their income. You then have something to pass on to your children, and so the children then don't have to do the work of the parents. Actually, can go to school. Is what happens.
Organizations that you've led have worked or been inspired by the Camden Coalition.
Yeah.
And do you think that this multiplier effect would also have been maybe helpful in some of these low-income urban centers in the United States?
Absolutely. Yeah, I do think so. I think what I love about Camden is it really engages the community as well. I mean, I think so much I know we're reframing healthcare. So much about healthcare has been prescribed by really smart people doing really good things. But I don't know how often we really ask our community. I don't know how much we really understand the needs of our community and what they think about health, and what would motivate them. Yeah. So it's been a while since I've seen their work, but from what I recall, that's what they really have done an excellent job.
Yeah. I mean, where I'm going with that is I'm trying to understand what have you learned in your global health work that you didn't know when you were an executive in American healthcare system, and what do you wish you had known?
There's a lot there. So in healthcare system, what do we call the individuals we care for in the healthcare system?
Patients.
A patient. Yeah. So we've already given them a label and a title of what they are. What I like about the work in the development space, and includes healthcare, they call them beneficiaries. And a beneficiary is we work on behalf of somebody. We do something on behalf of. They benefit from our existence. What I think we miss the opportunity for in this country when we spend, what is it, Judson, 20% now of national?
Right there, yeah.
I mean, what other benefit are we providing to the communities for 20% of our gross domestic product? What else are we providing in addition to the medical care?
We'll go back to chronology.
Yeah.
So you leave an American health system, peak of your career.
Right.
What happens next? Where do you go next?
Yeah.
Talk us through where you've been the last few years.
Yeah, awesome question. So what we initially started to do was we created the Reiner Foundation. My wife and I have been planning for some time to give back to where we've been blessed and to do something of support in underserved communities, underserved populations, because we've been so blessed with so many things in our life. But we didn't know what we were going to do with that. We were partially influenced from what we had seen. We traveled the world quite a bit, and we've seen different areas. And of course, we could go right down the street and find different challenging areas we can support. But we kind of developed the belief that this country has so many resources and so many capabilities. Okay. And if it kind of got out of its way at times, it actually could take care of itself a little better. But there's so many countries that can't.
Okay.
So we created a foundation. The foundation said, what are we going to do? What are we going to do for work? And so we then kind of focused on this concept of well-being, and well-being meaning that well-being should be common to all. So we created an organization called Common Wellbeing.
Yeah.
And that was simply to look at levers, about what levers can be pulled, what things can we do in order to create conditions where well-being can prosper in underserved communities.
Yeah.
So we created an organization. We moved to Africa. We spent a lot of time meeting with other NGOs, non-government organizations, for those who don't know what NGOs are, learning what works, what doesn't work, look at large aid organizations, and kind of settled in the idea that we're going to create a couple of enterprises that we think combined together could create the greatest impact, and that's income and health. So that's what we've done. So we've created, our organization is called Common Wellbeing, and it has birthed, if you will, two nonprofit organizations in Zambia, one on income development, ending poverty through women, and the other is health access, using the community, improving health access in the community for maternal and child health.
Yeah.
All my time was in healthcare, and now we're actually working in development and global public health, completely different. So, yeah, every day is a little different, but we're gone back to school, read a lot of books, and literally moved our family to Zambia for a year to do a deep dive.
And in one of your newsletters, it says the family dog as well.
And our family dog. Yeah, we moved, my wife and I, 7 bags and our dog.
Okay.
Moved to Zambia, and we actually stayed in a house that was given to us for a couple of months by another NGO. We didn't even have a place to stay.
Wow.
It was my wife used the word commitment, and I didn't know what she meant by that, but I do now.
What would you call it?
It was commitment, but commitment to me was like, yeah, we're committed. When she said commitment, it was a different level. It means, oh no, we're gonna bundle up the house here and package. We're gonna grab our stuff. We're going overseas, and we're gonna learn. If we're going to do this authentically, legitimately, we have to have a lived experience that's very similar to what we are asking other people to help and support.
What would you say to somebody who might say, great, here's another American of means, white European male, going to an African country for a vanity project? Maybe you even had questions like that. How do you respond to someone that might question your motives, especially considering you come out of a faith-based system?
Yeah.
That might have, in the faith-based world, the missionary world, sometimes has a bad connotation to it.
Well, I've learned, older I get, that everybody starts from a good spot. And I don't judge people with their intentions. They may not be educated, or they may be very dogmatic in the way they do things. And we've seen there are incredible missionary things that are happening in Africa or in Zambia that wouldn't be done if the missionaries weren't there. Yeah, there's people want to do good because it feels good. They're not educated on if it's helpful or not helpful. So many things that are done. There are many, many, many NGOs that don't do much of anything, to be honest with you. They'll go do a few things. They won't measure the impact. But those are the lesser. The majority of the people in the community that we've found are incredibly, other nonprofit organizations working are incredibly oriented. They're very communal. Even the NGOs working together, they problem solve together. They do a lot of side-by-side partnerships. Imagine if we did that in the United States with our healthcare.
Yeah.
We kind of say that. We have coalitions, but they're not natural. In this space, people who are trying to help people in these disadvantaged countries in a structured, organized way are very collaborative. And they're very generous with knowledge and information to assist. So
I'm not super clear on how a non-government organization compares with a domestic nonprofit. Are there differences in the way they behave?
Yeah, it's very much a public health universal term.
Okay.
Humanitarian or development is an NGO. It's a non-government organization. It's a nonprofit.
Okay.
So in this country, you'd call it a nonprofit. There you call it an NGO.
Okay.
NGOs are generally in the spaces of humanitarian or development work. Nonprofits here could be the arts. There's many different forms and structures of what a nonprofit can do in this country. It could be academia, It could be churches. When you deal with NGOs, it's primarily humanitarian development work or global public health work in disadvantaged countries or communities.
So you started 2 NGOs.
2 NGOs.
Kuwala and...
Anchor Health Partners.
Okay. So Kuwala NGO is focused on women in Zambia.
It's economic improvement. Women through women, and so the idea is that women can help end poverty. So we provide education, we provide resources for them, we help them create a business or a product, we help them take it to market. And the whole idea here is that helping them double or triple their income so they can support their families. And if that continues through business, then their next generation is cared for as well.
Why women?
Well, women are amazing for a lot of reasons, but women in Africa, or we have found in Zambia or in a lot of developing countries, they are the most passionate about their families, and it could be a culture. It's very much a cultural thing. But if you want to get something done in rural Africa, you work with women. Women do the cooking. They care for the children. They get the water.
Yeah,
they're the heavy lifters in the family.
If they start to ascend economically in the community, does that through income and job training, businesses, et cetera, does that change the dynamics of their culture or their marriages at home?
Well, the culture is very communal. So if they do it, they're gonna support each other. The women will support the other women. I would say they do, ironically, have to kind of get the support of their husband in order to, if they're going to start a business or do something. It's just it's part of their relationship and how they engage with each other. The women are the ones that are going to be most motivated for change, most motivated to try something different, and they take the higher level of responsibility for caring for their families.
What would happen if you just didn't have a gender specificity and you just invested in job training and education?
I think there would be a resistance from the men in the rural communities.
Okay.
Yeah, the women are hungrier. They're hungrier for their, because you know what, I think they take a deeper calling for caring for their family. Now, this is not general across every individual. But I think if you look at any of these poor developing countries, the women are the ones who carry the heavier water, literally and figuratively.
Have you had any challenges designing programs that actually work for a culture that's not your own?
Oh, 100%. What we do is invest in change makers in the country. So our program director for Kuwala, Zambia, literally came out of a village. She was the first one in her family to ever go to school outside of primary school. And so we invested. So we found her. We were interviewing for roles for the work that we were doing. Not exactly sure what we were going to do. We were very inspired by her. Because when she came, she'd had major lived experience. She also finished her master's in finance. So she, first one out of this, you have to see it to believe the community that some of these people exist in. In fact, we went and visited her home, and with her family. And this is a community that was eating every other day. Mm. Their wells were broken because someone put a well in at one point. They're literally hand digging a well to try to find water. And this is the environment she came from. And now she's leading an organization that's empowering women to take care of themselves. So all that we do is we inspire as an organization. We invest in them. We do capacity building. We help them we give them a grant to get started, but it's all led and managed by the local people to care for themselves. And when we're successful, we can pull back. We'll pull back over a period of time when they're able to self-sustain their own work.
How reliable are these metrics that you're focusing on, especially in a rural part of Zambia? How does that work?
Yeah, it's great. So one of the things we're pursuing as kind of a key marker of common well-being is a well-being index. So the well-being index is both a subjective and a objective measurement of well-being. So what's unique about having your own organization is you can create your own indices.
Yeah.
I mean, we could go out, you and I can Google right now or ChatGPT and find 1 million indices for well-being. What we have done is we've taken a population of about 100,000 and we're working on population health with income and health. And so we're going to measure over a period of time what the well-being is. So we're going to ask in advance, and we're going to review as we go. So how reliable? On an objective scale, they're very reliable. We know how much income they're making versus what they didn't make before. Everything we do is based upon monitoring and evaluation. So we do pre and post, and we check along the way. So if it's mortality, morbidity indices, maternal health, maternal mortality and morbidity, or infant mortality, we have all those metrics where we partner with the government. The cool thing about this, though, is I think well-being, if it's going to be motivational, has to be very subjective. So we're assessing now various capabilities of doing subjective assessments of well-being. And these are people that don't actually read and write. So we're engaged. We're looking at an organization now that actually uses pictures and color, like red light, green light, yellow, to determine where they are pre and post. Do they now have the ability to generate an income? Do they now have confidence in the health system that's around them, that when they show up, that Anchor Health Partners has helped support that organization with making sure there's equipment and supplies and infrastructure to do the work. So I think it's very, very measurable. And what I think is really cool about this is just not a sterile piece of data. It's actually subjective, because what do they feel? Do they feel like do they feel their life has improved? That they feel that there's conditions now that allow them to excel and for a brighter future for their children. And so absolutely measurable. I'm looking very forward to, 2 or 3 years out, kind of seeing what we have moved the dial on. And we're going to find some things that don't work 100%. I mean, we may find just as many things that don't work that do work. That's just the nature of the innovation.
Do you have any stories of impact maybe on a life or a family?
Well, the one I just gave you with, I would say, is our actual program director. If you really could understand the environment that she came from and where she is today, and now she's inspiring those people around her to actually do what she has done, that's pretty amazing.
You talk about a ripple effect. Was that an example of a ripple effect for this person, this director you're talking about? Did she have a ripple effect downstream?
She has now broken generational poverty for her family and for herself. And not poverty only in money, poverty in education, poverty in creating impact. There's many ways we can be impoverished. And so I would say her ability to get education and her parents' willingness to push her out the door out of a typical communal village type setting, to get an education, to aspire to do more, to give back. And what's beautiful about the Zambian people, and probably a lot of underdeveloped countries, they're communal, and they'll do anything to support their brother. I like aspects of individualistic community. I do think we would benefit in this country having more of a communal mindset at times. But she has broken the generational poverty for her family, and then for their kids and so forth. So yeah, she's a great example of what can be done with education, income, health.
You talk about the poverty cycle. Where do you see the poverty cycle cracking in Zambia?
Cracking in the sense of
beneficial, like the cycle is breaking.
I mean, you do have to create jobs, and the jobs can't be government jobs. So I think innovation. I think I see it through innovation in the sense of creating new businesses and opportunities. I think that's important. The thing about these developing countries, it's complicated, but they're the same. It's the same recipe. It really is health and income.
Yeah.
I mean, you can break the poverty cycle if they have actually are dealing with chronic conditions and go to work. You break some of the income cycle by providing training and development and support either through microloans and those type of things to get started. But all of these have to be oriented for them to do their own work and take their own responsibility.
Yeah.
It's not an aid organization.
Could a similar model work in the United States?
I wish our country would be a little bit more communal. I think there's a lot of benefit to having individuals support each other, to know your neighbors.
Yeah.
I think there are certain cultures that do that very well. I don't think in this country it's kind of designed that way. I think there's probably a lot of natural things or things that could be done that could make it better. I'm not sure I have those answers.
Yeah.
Today.
What should we try to do? Maybe the absence of a communal culture in our society is a barrier, but we have other attributes. Individualism.
Oh, incredible.
How do we use individualism as an advantage?
Yeah. I think it starts with having what are you being individualistic for?
Okay.
Is it for yourself, or is it for improving something around you? Is it something for a greater social good? The innovation in this country and the intellectual capacity, and there's just so much more that can be done. I don't know that I have those answers.
Yeah. Who does?
That's a great question too.
Health system executive, if you don't, where are these conversations taking place?
I think there are a lot of conversations happening. It's hard to get momentum. It feels to me, we're such a divided country, and it's really, really hard. I mean, in health system, it is hard to align people. I mean, first of all, you have to be inspired, and you have to inspire everybody. It's hard to inspire everybody when 50% want this and 50% want the other. So, if you use the context of how to make change, with even the complexity of making change in a large integrated health system, you have to create a common vision, and you have to inspire people, and you have to set a path and a direction, and not everybody's going to go that path.
So I'm hearing you say that you had 35,000 employees that your name was probably on their paycheck, and you still struggled to align those people around a common vision.
Incredibly difficult. Yeah.
That makes no sense to me.
Well, you can align at the basic level. I mean, I think at the individual level, you could take, it's like you could take the greatest good. What is our mission? In Adventist Health, living God's love by inspiring health, wholeness, and hope. Incredible. How you do that, it's a little different. Everybody has a little different perspective. I would say at a be perfectly candid, I think at an employee level, they get very inspired by a vision and direction of an organization. I think if you want to be, where the challenge happens is when you get into leadership and management.
Really?
Yeah. The people
So
that
the closer they get to you,
the more
challenging it is for you to
absolutely.
align.
Yeah, it was the most challenging part of taking an organization, creating a new vision, creating a new expectation around performance, a new attitude around performance, taking an organization that was incredibly gifted but underleveraged, and creating a common direction based upon a destination that was very numeric and metric driven. Everybody agreed to that in principle, and the people who embraced it the most were the employees, if you will. But when you get into leadership and management, it was tough, and the closer they get to you, the harder they can resist.
Why is that?
Some people go into leadership to create their own destiny, and they create their own direction. I think it fails at a system level when there isn't enough voice blended to create a common direction.
Voice?
So let's take an organization of 35,000 people. There are 100 people, give or take 150 people that really drive the organization forward on a day-to-day basis. It's their job. And getting them to agree upon a common direction is more than high quality, everybody should have a great experience, more than the specific things. But when you're really trying to drive towards performance, that means things have to change. That means systems have to be put in place that break the systems that they had in place before. That means that they're no longer responsible for something they used to be, because now we have an expert who's doing that. That may or may not be an expert, but that's what the belief is behind it. And so I think getting people naturally, the big idea is fine, but actually moving to an organized level of performance. And if you wanted to change their filters a bit and say, we need to be more than doing healthcare, when their entire career is oriented around medical care, not healthcare, it's even more difficult. It's like as a leader, you should spend at least 30% of your time in understanding the community that you're around and what the health needs are of the community.
Yeah.
Or investing in understanding various stakeholders' interests and how you're going to make them a beneficiary. It was very difficult. Their mind, it was very hard to get at times, although we had, I think, some great success. It's hard to move that.
I was in a meeting where you spoke, probably 2017, 18, could have been 19, I have no idea. You made a comment that American healthcare was heading for a cliff. What were you seeing?
Did I say that? Yeah, I probably did. Well, if you took, for us an organization, you had the revenue and expense lines cross, right? Even in 2017, we were probably, for us as an organization, probably most of the margin was coming off of our balance sheet.
Well, if you don't feel like you said that, then if you don't feel like you said that, we don't have to go that direction.
No, I can go there. Yeah. I did all these rounds. Maybe you might talk. I did all these rounds around the company.
Yeah.
I'm very inspired. Number one, Adventist Health. Employees loved it. Who hated it? It was management. They hated it. So I'd tell them. Maybe I probably did. I debriefed afterwards, very candidly. I wanted them to say, "Your staff love it." I said, what the hell's going on with you?
Yeah.
What's going on here?
Yeah.
Why are you so resistant? Oh, we're not resistant, or be passive aggressive about it. You may not like it, but now we have a vision. You may not like the lineup we have. We got probably over standardized. We probably got over centralized. I get all that. I would probably do things a little differently.
Yeah.
But
What would you do differently?
I think I would have definitely dialed back some of the centralization. I think what happened was we lost a lot of the individual character. You could lose some of the individual character of the organization by being too prescriptive.
How many hospitals did you have?
Today?
No, then.
Oh, we had 24.
24. So you have 24 different fiefdoms doing 24 different things.
Yeah, it's crazy. With 24 different, and you're only as good as the natural leader involved.
Did you have 24 different sets of outcomes, aggregate outcomes, quality outcomes?
Yes.
And probably your brand is on that. And you probably couldn't tolerate variation.
So maybe this is an interesting story. It could be. So when I interviewed for the CEO job, I'd been the chief operating officer for...
You're 47.
Yeah, 47. And my predecessor was retiring, incredible career with Adventist Health, and we got along great as my boss for a long time. And but we did things differently. We saw things differently. Had a huge respect for him, but we were different people, and we saw things differently. So when I interviewed with the board, these logical questions, typical interview about being a CEO. What you like to accomplish? What's your experience? And this and that. And I said, as a board, are you willing to change? Oh, sure, we're willing to change. I said, are you no longer willing to accept average as your target?
Wow, bold to say to a board.
Yeah. And I said, let me explain. So, and I kind of told them, our quality metrics are average, our patient experience average, our employee engagement's average. We don't have a unified approach. We're 24 hospitals in the state of California, of which we don't feel like we're a system. We're generally not invited to the big table or the small table.
What does that mean?
Of influence. We're not typically up next to the other major health systems in the country. When people call for advice and ask about input from the government or from the governor about what to do, they never call Adventist Health. Why is this? Why are we settling for average? Our mission calls us to do something more. Right. And I said, it will start with governance. I mean, we need to have everything we do in my thinking needs to be against top performing organizations. It's the Baldrige mindset. It's like we need to look outside and saying who's doing it the best.
Right.
Everything needs to be measured. And I said it was right for this board. Right. I said, are you willing to change seats in this board
if we need
different? Well, they were taken back initially, but then they really liked it. I said, are you willing at this board for people to come out of these seats and bring other people in the seats that are necessary to move this organization to a new level?
So you talked to the board saying, are you willing to step out of this board so I can get
not an individual, I'm not pointing at anybody, but conceptually, would we accept the fact that this board needs to be a high-performing board? And we're going to go test it to see if it is based upon all the, governing board science. There's millions of things out there you can test things to see whether your board. And are you willing to go through that exercise? Because it starts with you. If you're not willing to do it, how can I get the rest of the organization to say everything goes under an attitude of performance and vision? And so if you're willing to reshape yourself in order to provide the overall oversight and governance of the organization, then I can do my work underneath that.
Wow. That's bold.
That was very bold. And I left, I thought, oh my gosh, what did I just do?
Yeah, I wish I had not said that.
I'm not even sure I kept my current job, much less the new one.
Never mind your aspirational goals.
Yeah, or out the door. But from that moment forward, the board subscribed to that. So we started the process of everything we do in the organization can be measured. And everything we measure should be a minimum of top quartile.
So you almost built like a manifest.
We did. We tried to create a manifest, a movement. The movement was trying to create with the actual leadership to go there. But we started there, and then we started to radically try to measure everything. And then when you started measuring, you saw the variability of an organization that does things at that point, 24 hospitals, 24 different ways. Some are fantastic, some are bad, some are average. It's like, okay, we need to normalize this. There wasn't essentially a common vision. There wasn't a put a man on the moon kind of idea, a moonshot, which in my experience gets people motivated in order to do something a little outside their normal calling.
What was your moonshot?
Well, the moonshot was at that point, it was evolving, but the idea is that we needed a moonshot.
Okay. That was enough.
That was enough.
Hey guys, we need a moonshot.
We need a moonshot. And it's something we probably will never completely reach, but it's something we're going to certainly, if you don't hit the moon, we're going to hit the stars.
Okay.
So, and I think that's what we started working on with the idea of, first of all, we had to kind of organize ourselves. And, we created the One Adventist Health concept.
I guess, why did you feel you needed to, what were you trying to change?
The only thing I could do, Judson, at that point is what would motivate me?
Okay.
It came from a very personal level. If I was going to be motivated in order to do something different, what would inspire me? One, I have to have a vision.
Okay.
I'm inspired by a vision. I'm very visionary. I mean, not saying I'm visionary, but I love visionary things.
Sure.
I know I'm not going to hit them all.
Okay.
But you have to have a destination that's different and greater than what you are. I cannot stand settling for average. Does our mission not call us to do something more than average?
Sure.
To stand behind that. So I think it started from my own internal frustration I was the COO of the company. I wasn't moving it forward to that level. I was running a hospital before that, and I didn't want anybody moving my cheese.
Right.
But when you get into a different seat and you see what's possible, then you have a different level of accountability and responsibility. And that's where it started.
So the first thing you do, if I hear you correctly, you're saying, let's measure consistently across this entire enterprise. What did you see?
Average. Well,
did you see highs, lows, non-uniformity?
thank you. Of course, anything. Yeah, across they're going to have highs and lows. So the highs would be like highs. How can you help the lows? Well, it's really hard outside of a formalized structure to get one organization to speak to other, because it's a little bit competitive, right? So the idea is take the best out of the highs and replicate it across the company. And everybody had a high and everybody had a low. So a high may come out of a small hospital in Northern California and say, you're doing something amazing. We need to roll it across the system and we need to measure it. And we're going to drive to that level of performance. Or if there's you get it. So it's normalizing or going outside your own four walls and finding out how others are doing it, because your highs are probably not nearly high enough once you start looking outside your own walls.
If Scott Reiner hadn't been a healthcare executive on the West Coast, how would the communities that your hospitals were in have been adversely impacted?
If I had not been?
Yeah, if we hadn't had Scott Reiner in California, would people have had lower quality healthcare?
I would like to say you're making it very personal, which is fine, meaning that I understand the question, because I don't think it's about me. But I do think over the period of time, we did drive to higher results for our patients. I think that our level of engagement with our staff was improved. I think our experience was improved. I think the quality of our care, the level of our facilities improved. And I think we were fulfilling the gift. We were fulfilling the trust that we had in a lot of our communities to deliver on healthcare for them. I do think it was improved. And I don't just think it. Statistically, it was absolutely. We moved to top decile in many areas in the organization. And because of that, the income model changed as well. When the performance goes up, the bottom line goes up.
Yeah. And yet, what I understand of your leadership, you actually felt you needed to change again, right? So you actually brought in an entirely new mindset to how healthcare should be structured.
Yeah, so the first part was just, be honest, Judson, was just catching up.
Catching up to who?
Catching up to our peer systems that were outperforming us. So, the part of me is competitive. I just can't. We were under. I think the system was a little bit under leveraged of what it could do. So
what do you mean by leveraged?
Well, when you're running a $5 billion organization, you're in, I think, 15 different markets. I don't think we had the respect that was due us, given the nature of the work we're caring for. We're caring for 80% of our population was government, so we had very difficult
80%.
Yeah, 80%, either Medicare, Medicaid, Medi-Cal.
Were these peers that you're speaking of seeing that similar payer mix?
I'd say our payer mix was probably, I'd call it the most missional of all of them. I would say another peer system was probably equal. The Catholic system, very much like the same kind of idea. We're gonna work in communities that are difficult and have a lot of respect for them. There are a lot of community-based nonprofits that targeted more affluential communities to support so they could drive up their surplus.
Is that the wrong way to approach it?
No, just a different way. I mean, it depends what your calling is. I mean, you're not going to, if that's how you design your organization, that's what the result you get. Our purpose and our mission was really this. I think the populations we served, very proud of who we served. The communities we served are amazing.
Would you have turned down a 35% EBITDA margin hospital on the west side of LA?
No, not for a second. Because those are the ones that keep the lights on.
Yeah.
I mean, let's just get real. I mean, they're always in every organization. And the years depended, but there's most of your bottom line rests upon 5 or let's say 20% of it's 80-20 rule.
So how did the 80% and maybe rural bias affect the way you saw we should deliver healthcare?
The 80%?
Governmental and primarily rural.
We have to optimize and maximize everything that's available to us under the government structures. Okay. So we really We did it for mission, and we also did it because it was it worked. It helped us manage our cost structures, and that's the disadvantaged population were actually patients who we receive benefit from the government for, caring for. And so that was actually a wonderful scenario where we could create a little bit of margin to support the work and cared for a disadvantaged population. But if you're talking about the evolution of that was we needed to take an organization, we needed to create a vision, then the vision had to have, and then we had to create an attitude of performance, top quartile performance. That was just to get us to a competitive playing field as an organization. We had to satisfy our bondholders, our bond ratings, all this stuff. Everything had to grow. We had to have a mindset of growth. But the next destination, and maybe where you're going about the cliff in 2030, as I reflect back, that was a while ago, I think there's a few of us that felt we needed to find alternative revenue sources. Because if you're dealing with 80% government payer, and you're not closing hospitals, and you're not adding a lot of hospitals, there's going to come a time when the lines cross where your expenses are more than your revenue increases.
This is just trajectory of revenue, trajectory of expenses.
Yeah, your finance, you know that. You hit a line where it's probably uncrossed, but there's only so many costs you can take out of the system. So many costs you can drive out. And you can make a deep plunge and take out a lot of costs out, but they bounce back up because you still have a growth and you have a revenue problem. So we wanted to do two things. We wanted to extend the word of health into a broader definition of a healthcare organization. So we also felt we need to start to dabble and find alternative revenue sources that would actually prop up the entire mission, entire ministry of the organization.
Yeah.
So we founded a whole new division of the company around Wellbeing.
How were you going to monetize that?
Well, because every asset inside the division of Wellbeing had a profit by itself. So it's monetized because every entity itself is a business, and every business throws off profit and margin. And it wasn't so capital hungry. I mean, healthcare is hospital incredibly capital hungry.
So I'm hearing you say early on in is it 13 years?
Something like that.
Early on in your time, you're focused on the traditional leverage points, right? Which is cutting costs out, running efficient operations, delivering great outcomes.
Right.
Standard high outcomes.
Yeah.
But I'm hearing at some point in time, you shifted to maybe changing the incentives,
right,
and trying to get into a different game.
We'd done an amazing job in about 5 or 7 years of coming from, I think, an average organization to a top quartile organization. And when I don't say respected by peers, but having a voice in the game meaning you have an influence now that you didn't have before because you're known. We changed our brand in order to get that record. So we're now at a position of having a little bit more. And our financials has significantly improved. Now, how do we then do two things? How do we really fulfill our mission of whole person care? How do we extend the definition of health in our mission? And then how do we find new revenue sources? So the idea was then to create a new arm, a new thought about how the organization and where it could go. There was even a 2040 that we probably never got to because I left. I mean, so it could have been a very different kind of organization where the actual delivery of health services themselves were it's more that it's not what was leading the cart. Leading the cart was actual health significant. Really an organization focused on, if you will, capitalized health for the communities, health for individuals, that's monetized, that generates a margin, that becomes leading the cart, if you will.
Where do you think healthcare is going to be in 15 years, American healthcare?
It's going to take people like what you're doing. It's going to take some thought leaders. Someone's going to have to be really creative. I don't think it's going to come from the government. It depends but it kind of depends who's in the White House, who do they appoint, what is everybody's particular biases at that moment. This country is driven, it's a medical market, but it's driven by our financial model, which is another whole major conversation, which you're more of an expert on than I am, but our financial model is not intended to do what we're talking about. It doesn't reward and incentivize that kind of behavior.
Is there a way to bring that incentivization to our market?
I would think so. I mean, at some point it does have to stimulate from the government. Someone at some point has to declare that this country wants to be, the healthiest country in the world. And that means we're going to shift some investments, and we're going to shift some policy, and we're going we're gonna hang our hat on this versus something else that whether it be our military might or whatever else. I mean, what do we want to be known for as a country? Someone's going to have to be very bold like that. I don't see it coming immediately. And so it has to be done by individual organizations or I guess what could happen though, there's so much money in traditional provider systems today that if they do have the opportunity to throw off some margin, they could be very bold because there are so many systems that have integrated now that have come together, and there is critical mass there's enough critical mass if 2 or 3 major systems said we're going to create our own movement to do something a little different, and we're willing to put some of those margins in our big balance sheets to the test to create some innovation. I think you can move some things. I don't think it's going to come from the government.
We're seeing rapid changes even in the private equity space in healthcare, and somewhat naively here, I think private equity has moved towards value faster than the health systems.
Right.
If that's true, why do you think that might be true?
Again, I think it goes back to the payer environment. Most health systems are paid by the government.
Okay.
I think that's so.
Is that fee for service?
It's fee for service, capitation, cost based. You build your models around how you get paid.
Yeah.
Which is sad, but it's partially true.
Yeah.
And that's not to say the clinical care is designed there, but your business model is designed how you get paid.
Yeah.
Private equity is a little different.
Yeah. One thing you did say,
difference.
This one might be appropriately attributed. You did say a few years back, we've got to have a foot in each canoe. Yeah. And I interpret that in shifting analogies to be one canoe is Blockbuster. Maybe the other canoe is Netflix. Yeah. Help our listeners understand what that Netflix is.
That's a very good question. So if you take a very large health system that's sitting on a huge balance sheet, and I think you know what I'm talking about. They're sitting on billions of dollars of cash. And we say that because, there's going to be a rainy day. We have to have how many days of cash do we have on hand, really?
It depends on the bond rating that you're looking for.
So everything's driven by finance. What if these large integrated health systems say and there are some people that are incredibly innovative and doing some amazing things. And I'm not, I was just thinking of some systems. Northwell in New York, so just incredible, amazing, unique things.
Michael Dowling.
Yeah, we need them. We need them to step up and create a movement. I don't think it comes from the government. And if the energy and the amount of money that rolls through health systems, they could get venture capital support approaches. So I just don't think we've thought outside the box as overall. Overall, I'm saying there are those who have. And so I go back, I'm thinking back on your question. Yeah, it's not going to come out of policy. It's not going to come out of who's in the White House. Someone with a big balance sheet and a big desire for social good and a board.
Okay.
And a board that says, we're going to do something different. We've accumulated all this. We've accumulated this entire balance sheet based upon the margin out of this communities. We're now going to reinvest. I mean, what if an organization of $5 billion, if you could, it's a nonprofit. What if you put if they're sitting on $2 billion of cash, what if you just put that into an endowment and started doing amazing things?
Yeah. What advice would you have for the next 47-year-old Scott Reiner that's taking over a $6 billion enterprise and they've got a 15-year run ahead of them? What are they focused on?
Maybe it's a quick story, but so I was 47 years old. I kind of thought maybe I'd get the assignment to be the next president of the system. Fully prepared in my head. I knew what I was doing, right? And about 2 weeks into, maybe a month into my assignment, I had get freaked out. I was getting very anxious, had anxiety. I started realizing, am I really ready for this? Mm-hmm. So there's a theme to this, and that we're just assuming the individual's ready to do the job. Not everybody's prepared to take on that large of an assignment or that large of an opportunity. For me, it was the fear of failure that came out really pretty quickly. Even though I've been doing that my entire career, I finally realize now that after I've broadcasted what I intend to do, want to do, then you look in the mirror and thinking, oh my gosh, that was me at least. And then I realized, was I really prepared for the role? Do I really know what it entails?
Yeah.
And so I'm a big proponent on coaching and getting people prepared.
Okay.
And so got an executive coach who was very instrumental. And the first question he asked Judson when our first meeting is, why do you want to be a president of this organization?
Whoa. What was your answer?
I had to answer him the next week.
You couldn't even answer him.
Now, this is me. I mean, vulnerable. This is my life.
Was there like an internal emotional response as he asked you that question?
Oh yeah. It's like, well, of course I know. Well, it's because I've been groomed to do this. I've spent my whole career doing this. And it became that journey of unpacking why I wanted to do something that came to a very authentic. So even maybe I didn't question the way you asked it. If someone is going to run a health system or any organization today that has 35,000 or 50,000 employees, boy, they better do it out of a point of who they are authentically as an individual. If they're doing it to put a marker, I always wanted to be a CEO, or I believe I can change the world, whatever. I think if they're not personally prepared for it at a very deep individual level, I don't think it's going to go very well.
What do you think would happen to them if they didn't have?
I think they become inauthentic.
Okay.
Yeah, and I think that they'll start pushing for things possibly that are outside their natural, either their natural abilities, their natural inclinations. And I think inauthentic leadership creates a problem if you're creating a movement or have a vision about what to do next, or creating a vision to motivate people to go somewhere else. Inauthenticity, doing it just because it sounds good, or you worked it up on ChatGPT. This is my plan, and it sounds great. Let's go.
Yeah.
People will see through it, especially people in healthcare. They're very, they're much more in touch with their empathetic side, and they're going to see it. And so for me, it was like, oh my gosh, I could actually fail.
Yeah.
And am I ready for this? And why in the heck am I doing this? Yeah. And then when someone asked me at a very quiet, deep moment, it's like, why did you want to be the president? I couldn't answer them.
Wow.
So now you move that forward a year or two, I can name a million reasons why I wanted to. So to me, when you asked that question, I went to a very deep level, not so much about, hey, I want to do this, 47, I want to do. It's like, what do you really, are you prepared? What do you really want to do? And what are you personally willing to sacrifice to make that happen?
Yeah.
It's very different.
So you're 47 again, and you get offered another $6 billion system. What's your answer this time around?
Well, I enjoy what I'm doing right now a lot. Where I would start, honestly, would be governance.
Governance.
Advisors. I would choose. I wouldn't take a role unless I could work hand in hand in creating incredible our incredible generative thinking board, and I would infuse it with external advisors. Healthcare is so. You've been to them. It's like health meeting after health meeting or conference after conference. We're all talking to each other. I don't think we listen to outside influences enough. All sectors.
Yeah.
And I think I would use that to frame the board. And I would say, what are we going to do with the assets that we've been given? And it's not that we have to go from 12 to 14 or 8 to 10% EBITDA. It's something much bigger than that. So to me, if I was going to do something it would be very much vision casted about driving down the lines of health. I probably would be very similar to what I was doing when I left Adventist Health. I think we have to create new avenues of health, both for service and for revenue. I think there has to be a very a different approach.
Would you say that this vulnerability, this learning, this maybe humility that you learn through the job, does that contribute to the work that you're doing today in lower income countries? Yeah,
I think that's where I've been all along. As a person.
You've been there the whole time.
Yeah. And I think the challenge you get when you get into large organizations and bureaucracy, and I'm hoping I'm not coming across in a negative way, because this is the way these things work. But I think
what works?
Well, I think, or big organizations like this have to have these infrastructure and these pieces. And I'm not downing bureaucracy and structures and governance and conferences. But for me, you can very easily lose track of who you're serving. There's a word, I guess I already used it earlier, beneficiary. I think I may have said that.
Yeah.
Who are we entrusted to create benefit for as a leader of an organization?
Do these big organizations need to be that way?
I think they do, but everybody has a different perspective. I mean, at the end, what would you feel? You're a patient, you're a consumer in the community.
Yeah.
These are community assets, essentially. They're nonprofit. What would you want? What would you think the leader should be like? What would you want the leader entrusted to do that? What are the characteristics you think would be important?
Well, I mean, I think they should have the best interests of, I used to think the patient, but I now think probably the ecosystem around the patient probably needs the focus. Yeah. And I think that's where the health leaders need to be focused.
Correct.
And they need to remove themselves from the center of the conversation.
Yeah, I agree.
You and I are having this conversation. What would you say to somebody that would say you two have lost focus on the core product?
Well, health is not one product. I mean, the one thing I'm learning in the space I am is we're very egotistical in healthcare, traditional, very egotistical that we have all, you just said it, the solutions to all the problems. We can fix anything in this room today.
Yeah.
We can just do it because, we're smart people. We got resources, we got some cash. I mean, if we don't realize that we have to have other partners to step up on beside of us that have different competencies, that have different interests, I think the next generation of healthcare is actually really defining health and bringing others alongside them. There could be some periods of development that are necessary.
Yeah.
There could be education. There could be so many natural pieces. I'm a big proponent of well-being. I would hope the next health organizations, the next round would actually be much broader thinking. Being a patient is a symptom of something that's happened. Right? Yeah. So there are people before they're patients, and there are communities before. Communities are made up of the individual people and the collective thought. So, in the community, I don't mean just natural geographic community. I mean community of thought leaders, community of people that are aligned or are engaging in different communities that can help influence your work.
Yeah.
And so, I think the next generation would be along those lines. I think you answered it.
Can we build sustainable community-driven models in the United States?
That's a great question. I know we're working diligently in other countries to do so. And I think there is natural innovation and opportunities. I'm not saying they're huge businesses. I think we should certainly strive to do that. If we're going to build community trust, I think we need to put some of our resources in helping the community elevate the new definition of health.
Yeah. What do you want your legacy to be?
I didn't even think about legacy until about 2 years ago. I always thought it was a very egotistical thing. A legacy. Why would I have a legacy? It was a little naive on my part. And legacy is not, of course, that. Of course, legacy is something that you may be known for or something you leave behind. And I would hope that I would leave behind an authentic person who sincerely wants to help people and all the infrastructures that are man-made or not. And whatever aspect of service that I could provide, whether it's running large health systems or helping individuals in a disadvantaged community in America or in Zambia, Africa. I would hope that the legacy was that you combined social good with innovative thought, and you scaled it to a point of helping the largest impacted number of people you could.
Thank you, Scott, for your time today.
This is awesome.
Really appreciate it.
Yeah.